Good day. Today's topic is going to be on bleeding and clotting disorders. So hemostasis is a process where clot formation occurs in our body to arrest the bleeding. So when there is an injury site, there is usually collagen exposure, activation of the platelets that takes place, and the aggregation of the platelets, which forms a plug to arrest temporary bleeding. So platelets and the coagulation factors or the clotting factors come in play when these two are defective, as in the platelet plug that is formed if there is not proper aggregation of platelets, or if the coagulation factors do not work properly, or there are less in number, there is going to be a bleeding disorder or a clotting disorder. So the coagulation cascade, what do we know about that is coagulation cascade has two pathways, the extrinsic pathway and the intrinsic pathway. So the extrinsic pathway, how you remember this is when there is tissue exposure, so extrinsic and exposure, EE. So when there is exposure, there is tissue factor release, and along with tissue factor there is factor 7 that is activated into 7A, which in turn activates the conversion of factor 10 to 10A. Okay, so the 7, 10, the numbers all that we are talking about are the clotting factors. So in the extrinsic pathway there's just factor 7 and factor 10A activation. After factor 10A activation becomes the common pathway, which further leads to conversion of factor 2 to 2A, which is conversion of prothrombin to thrombin. Okay, so this thrombin or clot formation, this thrombin formation further leads to fibrinogen to fibrin conversion or the fibrin clot formation. Okay, so similarly in the intrinsic pathway, if you see, there are multiple coagulation factors that are involved. Initially there is factor 12 to 12A conversion, 11 that which then activates factor 11A, and from 11A it is 9A, 9 to 8A, 8A to 10A, which then forms the common pathway. Okay, so this factor, this extrinsic and intrinsic pathway is not very simple as such. So when you see on the right side, the molecular cell-based model of the coagulation cascade is a little more complex. So initially what happens is the box here, which is the initiation, happens. So here the conversion of factor 10A from the extrinsic pathway, which is tissue factor binding to along with factor 7A, leads to the conversion of factor 10 to 10A, and then there is thrombin formation. So this is the initial step. The thrombin formation from the extrinsic pathway is the initial step or the initiation. The second step is called the amplification. What happens is small amount of thrombin that is formed usually then activates factor 8A, factor 11A and factor 5A, further leading to conversion of factor 10 to 10A and more amount of thrombin that is formed. So 5, 11 and 8. Along with factor 8 to 8A conversion, there is von Willebrand factor, which also plays a role, which is responsible for carrying the factor 8. So von Willebrand factor also leads to the conversion of factor 8 to 8A, then leads to more thrombin formation, further by then causes more fibrin or clot formation. So this is the second step or the amplification. So by this amplification, there is still more activation of platelets also that occurs in the clotting pathway. So these activated platelets, what they do is they get attracted to factor 10A, which then combines with factor 5A, okay, and then forms a prothrombinase complex, which further induces conversion of prothrombin to thrombin. So this step of amplification takes place, and the conversion of prothrombin to thrombin further by combining of factor 10A and 5A to the activated platelets is called the propagation. So by more amount of thrombin that is formed during these steps, there is more amount of fibrin clot that is formed. Okay. So the antithrombotic pathway, why this is important is the clot that is formed has to be temporary because it has to stop bleeding at that site, and cell injury or repair should take place. So after which the clot, if it is present in the vessel, is going to cause problems. So there has to be a pathway to stop this clot from forming also. So this is by various steps. The first thing being thrombin combining to thrombomodulin, which is another endothelial cell enzyme. So this, when combines to it, forms activated protein C or protein C, and this activated protein C along with protein S inhibits factor 8A and factor 5A in the intrinsic pathway. So when 8 and 5 have been inhibited, there is no conversion of factor 10 to 10A that takes place from the intrinsic pathway, thereby inhibiting thrombin clot formation. The next one is tissue factor pathway inhibitor, which then inhibits tissue factor, so thereby also inhibits factor 10A formation. So there is, from the extrinsic pathway, there is inhibition there, so 10A is not formed, and when the 10A is activated form of clotting factor 10 is not formed, there is furthermore the step of prothrombin to thrombin conversion also does not take place. Antithrombin then, which is another a protease enzyme, inhibits factor 10A and thrombin conversion. So the other one here is on the right is C1 esterase inhibitor, which is another protease enzyme. So this prohibits the conversion of 12A, formation of 12A and the conversion of 11 to 11A, thereby inhibiting the next steps in the intrinsic pathway. So with this, all of the antithrombotic pathways will be arrested, so that the thrombin clot formation will be stopped. So after this is what is called fibrinolysis that takes place. But this happens, and along with plasminogen, with the help of plasminogen, so fibrin degradation products form, and this process is called fibrinolysis. What we know now is about the uh, coagulation cascade and the factors that are involved in this pathway. By knowing this, we know as to which factor is involved in which pathway, and thereby which disease can be caused. So if it is a bleeding or a clotting disorder, roughly on a whole, what are the clinical manifestations that can present are, if it is a mild disease, there are no clinical signs present. If there are severe coagulopathies, the skin and the mucosa can be involved, which can lead to, it can range from petechiae, purpura, ecchymosis, hematomas, or jaundice. There can be deep dissecting hematomas and hemarthrosis or bleeding into the joint in hemophiliacs, which can further lead to death. Disorders of platelet quantity can cause hepatosplenomegaly, spontaneous gingival bleeding, and patients will be at a risk of hemorrhagic stroke. The types of diseases can either be a vessel wall defect, okay, like senile purpura, Osler-Rendu-Weber syndrome, Ehlers-Danlos syndrome. It can be a platelet disorder, wherein the quality of the platelets, although present, will be faulty. It can be drug induced, such as when the use of aspirin or indomethacin. Thrombocythemia, where there is an increased number of platelets, and cytopenia, there is decreased number of platelets. The coagulation factor deficiency or inhibitors will be deficient, or the diseases that can be under this category are hemophilia, von Willebrand disease, disseminated intravascular coagulation, wherein both clotting as well as bleeding happens at the same time. Vitamin K deficiency, because there are certain factors that are dependent on vitamin K to be produced in the liver. Heparin or oral anticoagulant therapy, and renal disease. Okay, and you maintain it for 5 minutes. There can be petechial hemorrhages seen on the volar surfaces of the arm, which is distal to the antecubital fossa. Okay. So the size, these fossa, these petechial hemorrhages can be the size of a quarter 2 minutes after the defusion of the cuff. Okay, so in the volar surface, you will be able to see hemorrhages, petechial hemorrhages. Okay, so for vessel wall defect, there's just one test to identify, but for platelet disorders, there is the first test, which is the platelet count that can be measured. So if it is about 1,50,000 to 4,50,000 cells per cubic millimeter, is considered to be normal. So anything in the range of 10 to 20,000 cells will be difficult to treat, and spontaneous gingival or bleeding, internal bleeding can be seen, clinical hemorrhage can be seen. So this is an indicator where you have to transfuse platelet. So bleeding time can be calculated. It's a modified IV test wherein there is a small incision that is placed on the forearm, and again, like the Rumpel phenomena or the capillary fragility test, a blood pressure cuff is placed, and about 30 mm of Hg is it's raised to this level of mercury, and then at the incision site, the wound there is blotted with filter paper and monitored until absorption of blood on the paper ceases. About 1 to 6 minutes is normal. So more than 15 minutes is prolonged, and it can be a sign of 1 milligram disease, thrombocytopenia, or platelet function disorder. So the test for other coagulation disorders, like I said, there are 3 types of disorders. There is one test for um, vessel wall defect, 2 tests, that is the count and the bleeding time for platelet disorders, and for coagulation disorders there are a number of tests. Depending on the factors involved, there can be tests for the intrinsic pathway, for the extrinsic pathway differently. So first thing is the prothrombin time, the PT and INR. So INR is international normalized ratio. So this is taken into account when the patient is on anticoagulant therapy, and the ratio is usually 1. So what PT, prothrombin time, does is the time taken for prothrombin to convert into thrombin. So the extrinsic and common coagulation pathways will be evaluated here. So it checks for the presence or the absence of fibrinogen, prothrombin, and factor 5, 7, and 10. So only the extrinsic pathway, the factors involving the extrinsic pathway, will be evaluated here. So this is not effective for factor 8 or 9 involvement, such as to identify a disease like hemophilia. The normal range is 11 to 13 seconds. So INR is introduced by WHO in 1983 and is the ratio of prothrombin time that adjusts for the sensitivity of the thromboplastin reagents such that a normal coagulation profile is reported. Usually, if the patient is on anticoagulant therapy, the INR value is supposedly to be between 2.5, 3.5 to 4.5. So it is best to bring it down below 2.5 when the ratio for every other normal individual without a bleeding or clotting disorder is 1, and any patient with anticoagulant therapy is supposedly to be higher. So you bring it down before we do any necessary procedure for surgery for such patients. Activated partial thromboplastin time. So this is for the intrinsic coagulation pathway, where it checks for factors as in the deficiency of factor 8, 9, 11, and 12. So how we do this is calcifying plasma or calcium chloride is added in the presence of phospholipid and a contact activator such as kaolin in the absence of tissue factor. Because if tissue factor is present, again the intrinsic pathway also the extrinsic pathway also will take place. So specifically to test just the factors that are involved in the intrinsic pathway, this is going to be done. So it is considered normal if we check it for 2 patients, one with having suspected to have a bleeding disorder and one patient who does not. So this APTT should be within 10 seconds of each other. Thrombin time, it's the ability to form, it's a test to identify the ability to form the initial fibrin clot, that is fibrinogen to fibrin conversion. Initially when it happens, you measure it by adding thrombin in vitro. You add thrombin to the blood, so you check it, and then if it is 9 to 13 seconds that the initial fibrin clot is formed, it's usually normal. If it is exceeding 16 to 18 seconds, it's prolonged. It is used to measure the activity of heparin and FTP, which is fibrin degradation products, and other paraproteins that inhibit the conversion of fibrinogen to fibrin. So FDPs can also be measured. We evaluate the presence of D dimers of fibrinogen and fibrin above normal levels. Usually FTPs are greater in disseminated intravascular coagulation. So we'd be able to identify this disease if the FTPs are greater. Vessel wall defects. So there are structural malformation of vessels, connective tissue disorders, and inherited or acquired disorders. due to which there are vessel wall defects and there can be bleeding, because despite of having normal platelet count or the normal clotting factors, if there is a vessel wall defect, there can be also bleeding disorders that can result. So one such example of a vessel wall defect is scurvy, so deficiency of vitamin C. It occurs in regions of urban poverty among infants that are poorly supplemented, and elderly who cook for themselves, who are not able to take care of themselves properly, wherein the dietary vitamin C level falls below 10 milligrams per day. So it is necessary for the synthesis of hydroxyproline, which is a important part in collagen formation. So one of the first clinical signs are petechial hemorrhages in the hair follicles, and the extremities in the lower back show petechial hemorrhages which coalesce to form ecchymosis. Hemorrhage can occur in the muscles, joints, nail beds, and gingival tissue. So gingival involvement may show signs such as swelling, friability, bleeding. Secondary infection can occur, and loosening of teeth. So the treatment is 1 gram per day of vitamin C should be administered to provide a rapid resolution. So these are the signs. As you can see, petechial hemorrhages that coalesce to form ecchymosis seen at the lower extremities, and gingival bleeding as well as swelling can be seen. So skin rash, scorbutic rosary of the ribs that can be seen. Wound healing is delayed because of collagen uh, not being formed properly due to vitamin C deficiency, and subperiosteal hematomas, hemarthrosis or bleeding into the joints, and bowing of the legs are I mean, one of the features, some of the features that are seen in vitamin C deficiency. The other vessel wall, the other vessel wall defects include Cushing syndrome, where there is excess production of corticosteroids, which is a wasting disorder, and there is connective tissue atrophy around the blood vessels, so which leads to bleeding. Ehlers-Danlos syndrome, which is another connective tissue disorder, which is inherited, showing fragile blood vessels and easy bruising. So it's identified by hyperelasticity of skin, mucosa, and joints, and there are pulse nerves that are seen. Brendo-Osler-Weber syndrome, or hereditary hemorrhagic telangiectasia, wherein telangiectatic capillaries, nasal and gastrointestinal bleeding occur. Perioral and intraoral telangiectasias are seen, involving the areas of the lips, tongue, palate, which may bleed on manipulation. The disorders of platelets can be either congenital or acquired due to the use of drugs that is acquired, or due to other reasons which will be seen. It can be thrombocytopenias or cytopenias. Okay, the congenital abnormalities, if there is a defect in the receptors present on the platelet surface, so there can be difficulty in adhesion or the aggregation of the platelets, or if the receptors are normal but there is a signaling issue between the two platelets or the transcription factors, which is important for the production of the functional platelets, there will be a congenital abnormality of the platelets. Bernard-Soulier syndrome is the absence in the platelet membrane glycoprotein 1b from the platelet membranes. So, because 1b is absent, the von Willebrand factor cannot interact with it, and there is no platelet aggregation. Von Willebrand factor is present in the endothelial cell surface, which is important for platelet adhesion and aggregation. So, Lanzmann's thrombocythemia is a qualitative disorder wherein there is a deficiency in the platelet membranes 2b and 3a. So, these cannot bind to the fibrinogen and cannot aggregate. The next one is Wiskott-Aldrich syndrome. All these are congenital syndrome, which is X-linked recessive, where there is cutaneous eczema on the face, thrombocytopenic purpura, and increased susceptibility to infection. It is both a quantitative and a qualitative platelet disorder. May-Hagelin anomaly, which is a rare condition characterized by the triad of thrombocytopenia, giant platelets, and inclusion bodies in the leukocyte. So the acquired can be either it is idiopathic or it can be thrombotic thrombocytopenic purpura. Thrombocytopenic purpura. What can be seen is are petechiae and purpura over the chest, neck, and limbs, which are more severe in the extremities, and mucosal bleeding in the oral cavity, the GI tract, and the genitourinary tract. Causes can be alcohol and renal diseases. So, idiopathic thrombocytopenic purpura, it's usually self-limiting in children, but if it is in adults, it's indolent, usually common, and it is sudden onset, persistent over. It usually lasts for many years with recurrent exacerbations. In severe cases of ITP, oral hematomas and hemorrhagic bullae may occur, which are clinical signs. So young women are mostly affected. There is intracerebral hemorrhage, which is rare, but it's the common cause of death. It's usually caused by accelerated antibody-mediated platelet consumption. Autoimmune thrombocytopenia is associated with SLE, can be one of the syndromes that is associated with ATP. It can be occasionally severe and serious. So the immune-mediated thrombocytopenia may occur in conjunction also with HIV disease, and it is usually present in 15% of the adults in patients with HIV, and it is one of the common with advanced clinical diseases in immune suppression. Thrombotic thrombocytopenic purpura is a catastrophic disease which is fatal. The causes are metastatic malignancy, chemotherapy, and pregnancy. Features include microangiopathic hemolytic anemia, fluctuating neurological abnormality, renal dysfunction, fever, and microvascular infarcts in the gingiva. Treatment for either of which includes corticosteroids, splenectomy. So, in chronic ITP, to prevent the antiplatelet antibody production and sequestration, the removal of the antibody-labeled platelets is one of the treatment options. Plasma exchange with aspirin and dipyridinol is another antiplatelet. Along with the corticosteroids, lowers the fatality of thrombotic thrombocytopenic purpura. Fresh frozen plasma can be infused. Platelet disorders can also be drug-induced. The drugs involved can be chemotherapeutic drugs that cause bone marrow suppression, which can lead to thrombocytopenia. Antiplatelet drugs for ischemic heart disease, prosthetic valves, stents, myocardial infarction, or stroke can also cause a platelet disorder. So, when aspirin is given, what has to be taken in mind is that it produces it causes an irreversible production of thromboxane A2, and the half-life of platelets is about 7 to 10 days. So, which means the platelets antiplatelet action is persistent for about 7 to 10 days when we take one dose of aspirin. So, if any procedure that demands to be done, it has to be stopped. Aspirin has to be stopped 7 to 10 days prior to the procedure that can be done. Treatment of these platelet disorders, you can transfuse platelets, maintain to about 10 to 20,000 cells per cubic millimeter. But repeated transfusion can cause antiplatelet antibodies to appear, so that has to be kept in mind. And if the donor is giving you platelets, you have to match the HLA subtype for these donors and the receivers. Plasmapheresis can be done to remove the isoantibodies. Coagulation disorders, they are congenital or acquired. Congenital can be von Willebrand disease of hemophilia, and acquired can be drug-induced, either heparin or warfarin. So one of the diseases are von Willebrand disease. So von Willebrand factor is a factor that is found in the endothelial layer of the blood vessel. So this is responsible for carrying factor 8, also for the adhesion and aggregation of platelets. So what happens is, when this is a normal physiological process that occurs, von Willebrand factor helps in the adhesion of these platelets by binding to the receptors on the platelets 1b, 2b, and 3a. So if it is deficient, there is going to be no platelet aggregation, resulting in bleeding due to smoke. So the von Willebrand factor disorder can be due to the qualitative and quantitative defects in the von Willebrand factor. So it can be both platelet and coagulation disorder, because von Willebrand factor is required for platelet aggregation as well as for carrying factor E, and the types can be of 3. The first one is partial quantitative defects. The quantity of von Willebrand factor is partially missing. Qualitative defects, wherein the addition of platelets does not take place due to the multimers of von Willebrand factor being reduced. 2B is the increased affinity to just glycoprotein 1B. 2M is defective platelet addition despite normal multimers, as in the pure qualitative defect wherein the multimers are there but they do not function properly. 2N is reduced affinity to factor 8. And the third one is complete absence of von Willebrand factor. The symptoms are the skin can easily bruise, nose bleeds, gingival bleeding, and heavy menstrual flow or bleeding after childbirth. Laboratory findings here, because it's von Willebrand factor that is involved, it has nothing to do with any of the coagulation factors or that of the platelets. So the bleeding time and the partial thromboplastin time or prothrombin time or the platelet count are all normal. And the ristocetin test, ristocetin is an antibiotic that is added to see if the von Willebrand factor binds the platelets or causes the aggregation of platelets or not. It's an in vitro test, that is an antibiotic added to blood to see if von Willebrand factor is available to make the platelets adhere to each other, causing a clot. So that is going to be abnormal. Treatment is desmopressin, which is an analog of vasopressin, which releases von Willebrand factor and factor 8. So both of which are important for the platelet addition or in clot formation. You can replace this von Willebrand factor if not. And contraceptives also help in increasing the amount of von Willebrand factor and factor 8. So birth control pills can be used for the treatment of von Willebrand disease. The next one is hemophilia. Hemophilia can either be inherited and also because hemophilia is the absence of either factor 8 or factor 9, and because factor 8 the multimers or the number of factor 8 in the body is also influenced by von Willebrand factor. If there is going to be a von Willebrand factor deficiency also, there is going to be more amount of factor 8 that gets broken down, so that factor 8 deficiency results, furthermore leading to hemophilia. So hemophilia A, which is classic, is the deficiency of factor 8, and hemophilia B is Christmas disease, which is the deficiency of factor 9, which is why there is going to be disease present. Acquired hemophilia, it can also be due to other causes, due to liver failure, because clotting factors are formed in the liver. There can be hemophilia that results, that is factor 8 and 9 if there is deficiency due to liver failure. Vitamin K deficiency, because factor 2, 7, 9 and 10 are required, are dependent on vitamin K. There can also be vitamin K deficiency that can furthermore trigger the deficiency of other factors that causes hemophilia. Autoimmunity against the clotting factors, if there is going to be autoantibodies produced against the clotting factors present in the body, there is going to be a deficiency that results. Disseminated intravascular coagulation, which consumes the clotting factors, that is simultaneous clotting and bleeding that occurs in the body. So hemophilia A and B, both of which are X-linked recessive, that affects men because even though if the female has a mutated copy of hemophilia that is transferred from the mother or the father, she is going to have another healthy copy. If the men in the family or the offspring is a male, one mutated copy, so he will be receiving, if he receives another mutated copy from the female, it is going to be affecting only the males and not the females. The females are going to be carriers of the gene. So the signs and symptoms, they are nearly identical for hemophilia A and B. There's easy bruising or ecchymosis, hematoma, collection of blood underneath the skin and that of the mucous membranes, prolonged bleeding after the cut or surgery, and oozing after extractions. GI bleed is there, hematuria, severe nosebleeds, and hemarthrosis, that is bleeding into the joints. Okay, so for the diagnosis of hemophilia, the lab tests, or that is the platelets, the prothrombin time are all going to be normal because they are of the prothrombin time is to check for the extrinsic pathway and has nothing to do with factor 8 and 9, but then the intrinsic pathway, which involves factor 8 and 9 for the activation of factor 10A, is going to be abnormal. So partial thromboplastin time is going to be affected. And for the confirmation, you have tests for specific factor activities, as in the number of factors, uh, as in the percentage of factors in the body usually is maintained over 200%. So when you check for the factors, you will know that it is deficient. Treatment is you replace the factor that's missing, simple as that. That is the factor 8 or factor 9 that is missing has to be replaced. So you can give desmopressin in case it's only the factor 8, it is hemophilia type A, wherein factor 8 is missing. So DDIVP will increase the amount of non-virulent factor, thereby the increase in factor 8. Okay, the next one is a drug-induced clotting disorder. So heparin plus antithrombin will inhibit the clotting enzymes, reduce fibrin clot formation leading to bleeding. So duration of action of heparin is about 3 to 4 hours. So 1000 units per hour unfractionated heparin is given for anticoagulation. Low molecular weight subcutaneous heparin 5000 to 1000 units per 12 hours is given. And for chronic cases, coumarin anticoagulants are preferred. The antidote for heparin is protamine sulfate. So warfarin and dicumarol. So these group of drugs are anticoagulants that are given, due to which there can be bleeding if an injury occurs. So warfarin for atrial fibrillation prosthetic heart valves is given. So they are at a risk of thromboembolism. And daily doses of 2.5 to 7.5 milligrams of warfarin is given. It has a longer duration of action when compared to heparin. So with coagulant activity in the blood decreased by 50% in 12 hours and 20% in 24 hours within the initiation of therapy happens. So when you initiate therapy, only the activity of blood is decreased by 50% in 12 hours, which means it takes a longer time to act, and it is going to act for a longer period of time also. Coagulation returns to normal levels in approximately 2 to 4 days following discontinuation of coumarin drugs. So the symptoms after taking heparin or warfarin will be frequent epistaxis, increased menstrual flow, hematuria, easy bruising, bleeding from the oral mucosa, and prolonged bruising or bleeding from the superficial cuts. So dental considerations in patients with bleeding and clotting disorders are: first, you have to identify the patient if he or she has a history, if it is going to be an inherited disorder or not. You can ask the patient if there is a use of any anticoagulants which can affect the use of antibiotics and antifungals, because there are going to be drug interactions, preferably when warfarin is used. Previous dental history of bleeding episode after extraction can be questioned. Systemic conditions like liver, renal disease, malignancy, chemotherapy, and thrombocytopenia can also be asked for, or if the patient is a chronic alcoholic. The dental management depends on the severity of the disease. If it is mild, no change in the procedure can be required. If it is reversible, as in if the patient is on drugs and if it can be reversed when stopping the drugs, then the patient can be asked to stop. As in, for example, in the case of aspirin, it can be stopped provided the risk of thromboembolic stroke, as in if the patient is taking aspirin for an MI or for a stroke, it can be stopped only when the cardiac physician tells you that the risk for thromboembolic event is less and the extraction can be taken over with. If it is going to be irreversible, as in if the patient needs a factor replacement therapy, if it can be hemophilia, or if it's going to be 1 milligram factor that he needs replacement with, after factor is replaced, we can run the treatment. Initially, local hemostatics is required. You should also practice this despite the patient having a bleeding disorder or not. So pressure is the initial step. Surgical packs, vasoconstrictors, sutures, surgical stents, topical thrombin can be applied. Absorbable hemostatic material, fibrin sealants or fibrin glue, microfibrillar collagen fleeces, surgical foams are all available for local hemostatic. Susceptibility to infection. In hemophilia, hemarthrosis, that is joint replacement, is necessary because there is bleeding into the joints, and during joint replacement, antibiotic prophylaxis is also given. Anesthetic injections or dental instruments can cause trauma, which can lead to a hematoma that is formed in the oral cavity. So for these patients, antibiotics should be given. Pain control for patients who have already on aspirin. So no aspirin and NSAIDs to be given to bleeding disorder patients. So aspirin is an NSAID which has a function of antiplatelet action also. So NSAIDs furthermore giving them can increase bleeding. You should consult a physician always before any high risk procedures. And general anesthesia is usually preferred because if there is going to be extensive bleeding, the patient can get worried, and the treatment can be also delayed for the patient. So if it is general anesthesia, it is preferred. Nasal or endotracheal intubation is not preferred because the membranes are very thin and we can cause a bleed. Oral or endotracheal intubation is preferred to nasal endotracheal intubation. Procedures that can be done are supragingival scaling if you know that the patient is having a bleeding or clotting disorder. For subgingival scaling, if you know if it can be done with factor replacement, you replace the factor one quadrant at a time to be done. You split the procedures and do it. Antifibrinolytics and local measures can be taken. Rubber dam for restorative procedures so that you don't accidentally injure the patient's oral mucosa with a micromotor or with that of a probe. So intrapulpal bleeding has to be stopped with adrenaline. Usually the bleeding for primary teeth is going to be more than that of permanent teeth extraction. So again, you can replace it after the teeth have been exfoliated. So endo is preferred to extraction, and any surgery that is extraction is done only after factor replacement. Fixed appliances is preferred over removable appliances because chronic removal and placing of the appliance can cause bleeding of the oral mucosa. So these are the procedures that can be done. Platelet disorders. For platelet disorders, if there is thrombocytopenia, the initial or the ideal number of platelets to be maintained is 50,000 cells per cubic millimeter. So in thrombocythemia, it is managed with antifibrinolytics and local hemostasis is to be maintained. Patients on aspirin, you take the advice from the physician. So if there is going to be a thromboembolic event, the risk is more, you shouldn't stop the aspirin. If the risk of bleeding is more, you stop the aspirin only by taking the advice of the physician. So desmopressin is taken with aspirin to reduce post-op bleeding. Desmopressin increases endogenous release of von Willebrand factor and factor VIII. So in hemophilia, injections can cause hematomas, so you have to be careful while injecting the patient. No intramuscular injections. So the extravasation into the oropharyngeal soft tissue can cause hematoma, which is so large that can obstruct or can cause dysphagia. So we'll have to take that into account. And during extraction, a factor replacement is necessary. You replace whichever factor that is deficient and then go on with the extraction. So for replacement therapies, factor VIII and desmopressin are replaced for moderate hemophilia and von Willebrand disease. For extensive surgery, there is going to be desmopressin, cryoprecipitate, and fresh frozen plasma that has to be required. Antifibrinolytics like E-aminocaproic acid and tranexamic acid, they inhibit fibrinolysis by blocking the conversion of plasminogen to plasmin. So the clot formation is not broken down and it is in place. So in anticoagulant therapy, there is warfarin and heparin that is usually required for anticoagulant action. So when warfarin is stopped, its effects last up to 3 to 4 days. So for immediate surgeries, if the patient on warfarin requires immediate surgeries, so you replace it with that of heparin. So warfarin is given only if the thromboembolic event risk is less with the consent of the physician. Half-life of warfarin is 42 hours. So if the surgery has to be immediate, there is no use of stopping warfarin because it takes 2 days for its effects to wear out. Cessation of warfarin depends on the INR. Like I said earlier, the anticoagulant therapy INR is used for any patient on anticoagulant therapy. So it is, if it is less than 2 to 3, extensive surgeries can be done. If it is less, about 3.5 to 4, minimal surgeries with no dose modification can be done, but over 3.5 to 4, no dental treatment is advised. So the happen warfarin method is, warfarin, if the patient is on warfarin, it is discontinued because its half-life is about 42 hours. 24 hours before the surgery, it is discontinued and heparin is introduced and stopped 6 to 8 hours before surgery, because its duration of action is about 3 to 4 hours, or the half-life is 3 to 4 hours. Night after the surgery, warfarin is reinstalled, requires 3 to 4 days to restore anticoagulant activity, but post surgery again you reinstitute heparin. Okay, so if there is a bleeding emergency, protamine sulfate is given to reverse the action of heparin. So to overcome all this, there are new anticoagulants like dabigatran, which is discontinued one night before the surgery and resumed one day after. There is no post-op bleeding or complications that have been seen with dabigatran. It has a shorter half-life, quick therapeutic response, and minimal risk for thromboembolic event. Yes, thank you.